Let's start off with our first presenter, Monica Oss, and here are just some highlights. She's the founder and chief executive officer of Open Minds. She's the executive editor of Open Minds Circle and its industry market intelligence publications. She's previously held executive positions in the health insurance and managed care fields. And she's essentially a featured speaker and author of numerous books and articles on industry trends and organizational strategy in health and human services. And she's going to be focusing on a really important critical issues like do we really need to fail first. So Monica, please. And please join me in welcoming Monica.
Good afternoon. This is always, of all the heavy lifting I do at the National Council, this is the most fun thing because when I talked to Linda, she said you can talk about anything you want and feel passionately about. And 6 months ago, I really started, and if you see the name on the in the program, my focus has shifted slightly because I was going to talk about kind of the whole issue around consumers being forced to fail first on medications before they can get the medication they want. The more I started doing kind of research into this and thinking about it, I realized there's a whole bigger issue here, and it comes from a lot of my work in the field, which is I think in behavioral health and consumers with brain disorders, it's really not just medications, but it really applies to the whole group of new therapies, and there seems to be, I would call it a prejudice in the health insurance field, that consumers with mental health need to fail first on all sorts of things before they get access to new technology. So this really started me down the path of thinking about why is it that consumers with brain disorders have such kind of limited access to new things. And by the way, for those of you working in the field, if you don't think this is true, you just need to spend some time with people introducing new technologies who work in other disease states. I've done work with pharma companies, with people developing e-therapy programs. I did some work on the vagus nerve stimulation device when that was introduced. What all those companies tell you is they can't believe how hard it is to get new things introduced in the mental health space. That it's easier in epilepsy or cancer treatment or diabetes, but our particular market space seems to have problems. So we see, and I've actually been somewhat shocked this year, we're starting to see things like you can only go to the emergency room 6 times a year, that the limitations we see are starting to be very regressive. You have to fail first on cheaper medications to get one you think that fits. We don't see reimbursement really follow. What I consider to be the 5 million pilot projects that people have run and identified things that work, only to have them never be repeated because there's never any funding for any of these kind of proven and new models. And I will say this is not all an insurance company problem, which I'll get to in a minute, because I also see some real hesitance by clinical leadership in the field to also adopt some of these kind of new technologies. So my theory, and I absolutely love this chart for one line, is you've all heard about bending the cost curve. That our whole focus right now is we have to end that decline, that steady high growth of healthcare benefits, which is that red curve called normal, which I think is just an odd term in and of itself. And they show the piece in green, which is supposedly the bent cost curve. But the one I like the best is the blue one, which is defined as keep cutting and praying. But I think, as someone who is a trained scientist, statistician, chemist, I think we have precious little science that's really going into our approach to how we're managing benefits, and I think it has all kinds of negative effects. The other thing we do see, when you get aside from insurers, is on the treatment side, is that I think there's just this clinging to treatment as usual that is just the mantra of a lot of the clinical leadership that I work with. I realize, and I've got my master list here of why aren't new things introduced, they're not reimbursed, there's staffing issues, there's regulations, but in the end, even when you clear up those things, what I get from clinical leadership is it's just not the way I want to practice. I mean, so it's not, I think it's not just a reimbursement issue that comes out there. Now this is the very depressing problem. This is courtesy of my friends at Centerstone. I stole their slide. But it really is a great illustration, and anyone who's interested in the references, they're equally interesting. that in our space, it takes 17 years from the time science says we have a good practice to actually get it into clinical practice in any regular way. Now, at first I thought this was unusual, but I did some research preparing for this, and I didn't realize that it took 25 years for the stethoscope to be adopted. So, no, I did. It was a new learning of last week. But I think this is really a problem because what we have is this, I call it the sad gap. We have things we know work. We have consumers that are suffering from a whole range of behavioral disorders, and there just doesn't seem to be the alignment in place to reduce that gap to much less than 17 years. And so when you look at what I have here is a typical technology adoption life cycle curve. This does not apply to healthcare and particularly to behavioral health. If I drew this curve for healthcare, that I would say that mainstream market piece would be far to the right and about 2 decades in the future. And some of it is that there's just not, I think, the consumer representation in the field or the consumer market pressures to actually make those things happen. The sad piece is I think the new science to me is like incredibly wows me every day. I get up and read some new scientific journal. I think we know way more now about early diagnoses. We know that actually brain maturity now takes place when you're 25 or 30 and not when you're born. We know you can regenerate brain cells. I mean, we know that there's now a genetic and epigenetic role. There are actually interventions out there that are close to being commercialized, but they're nowhere close to actually being available to the people who really need them. So when you move beyond the science, these are the 9 domains of kind of emerging treatment technology. A lot of folks who are actually, I think, on the bleeding edge, and they'll tell you that from their financials, are down in the exhibit hall. They have lots of people here at this meeting talking about these technologies. I'm just not very optimistic that we'll see a lot of these technologies become commonplace before I retire. It's interesting to think about. So I did want to say just a few things about what are the, if you think about, they always call it the kind of science to service gap. I tend to think it's that all of this new treatment is caught in this Bermuda Triangle, that it is not just science and not just practice, but also includes some of our public policy. So I want to talk a little bit about each. On the policy side, I think we have 2 things that are huge problems. The past 4 years in particular, but even before, we have the politicization of healthcare policy. And personally, this is not a Republican or Democratic issue. I just call it's the anti-science issue. That we start to make policy around parochial political interests, religious interests. I mean, there's a long list of them. But they are really not very scientific, and that's one big problem. The other is the whole piece, and for any of you who work in policy jobs, please don't take this the wrong way, but a lot of people making policy don't know anything about how things work. So we get lots of regulation of process that in the end becomes an impediment to actually moving forward in the clinical delivery system. So I think policy is one of the 3 big issues about trying to think about how we fix that. There's a piece that is, having done a lot of work with FDA approvals, there's a whole approval process for new technology coming to market. One thing you may not be aware of is that most of the FDA approval process is really not designed for chronic disease. They use a randomized treatment control models, which are really set up for acute disease and single disease states, as opposed to using practice-based evidence models. If you are a consumer who wants to opt in early to a conditional use device or medication, it's very difficult to actually get that approval. So I think there's some real issues around FDA approval that are bad for anyone with a chronic disease, not just mental disorders, but any kind of chronic condition. I think we do have a tremendous problem defining what we mean by return on investment. That when you look at states, counties, health plans, and they do an ROI on a new technology, and we actually had this discussion on Saturday with a group of folks, You know, if an insurance company does an ROI, they're doing the ROI in terms of the length of term of their contract. If a state Medicaid department does an ROI, they do the ROI in terms of Medicaid spending, but never look at corrections or social service. I mean, it's a real frame problem when we start to look at, do things work and are they cost effective, because we're really not kind of looking at the right frame. The last piece, and I hesitated to put this in, and Tony promised he wouldn't throw shoes at me, is I think there's also a tremendous amount of guild opposition, and everyone hates when I use that word, but guild opposition to some of these new developments. There's, you know, to technological substitution, for changing in performance measures, changing in payment structures. I mean, I was truly amazed, just to give you an example, and since they're not here, I was amazed how effective the Hospital Association has been in reversing a lot of the readmission penalty plans for performance contracts that payers have. I mean, it's in one example of many of kind of strong guild thinking that really prevents change from happening at the field level. The other piece, you know, and I think we have a lot of lobbying, and that's not lobbying, by the way, is that my typo, sorry about that. There's right now a big battle going on in Washington about how much access should consumers have to data. There's pending legislation to make it illegal for you to own your own genetic information. I mean, there's been a huge brouhaha the past 4 months about Medicare databases and how public should they be in terms of access to the information. So there's those sorts of data pieces that are really blocking that. And then the last piece is really then the only advertising that we have in terms of what works and what doesn't comes to me courtesy of late night television advertisements for pharmaceuticals, where everything comes with a horse. I don't know if you've noticed, every pharmaceutical ad has someone riding horseback, which I find very appealing, and it always wants me to make me run out and buy that drug, even though I don't know what it's for. So, you know, because there's not a strong, I'm not at all in favor of limiting commercial advertising. I just think there's not a strong counterpoint of data for consumers to use to find information. The big piece is the piece in red on the bottom, which is I do think that how would I put this? I think earlier the goals of clinical professionals and consumers were fairly closely aligned, and I think that alignment has come unzipped slightly. And I actually think as we look to the future, there will be an out-and-out misalignment between a lot of professional and provider organization goals and what consumers really want and need. And I think we have to kind of anticipate, you know, that alignment is going to go away. So I came up with the, you know, kind of 5 recommendations. I think if I were to say, how do we try to knit together policy, practice, and science? I think 5 tangible things that you can do. You'll notice there's nothing in here about politics, because I think that is a hopeless cause. So I've stuck with the other 2 domains. I do think that there is some effort afoot to try to change how the FDA approves drugs, especially drugs for chronic conditions, and how they actually will permit conditional use or early use of drugs for consumers with severe illnesses. I think the comparative effectiveness work that's going on is good, but it needs to be more transparent and more presented in terms that consumers can actually use. I am a big one on public transparency of all data, provider data, performance data, cost data. You would be amazed as someone who's in the data business, how many states you can't get Medicaid data for and the state actually refuses to release it, which I find an oxymoron in terms of public purchasing. But it really is, I think the more transparent the data, the better. And I think always the tough one is, and especially tough speaking to a group of specialists, I think we need to do away with all the funding silos, because I think having pharmacy, mental health, radiology, primary care funded in different places is actually one of the bigger impediments to kind of bringing new technologies and getting them actually to consumers. So here's the thing, I really think we need to reinvigorate consumer advocacy organizations, because I think it's the only way to address this problem. I'm not sure you're going to find groups of providers or groups of county commissioners, or I'm not quite sure where it would come from. But I think we want to be thinking about how is the role of consumer advocacy different now than it was 15 or 20 years ago, that the consumer groups should be the ones focusing on these solutions to the policy and practice piece. And just a little recap, in other disease states, the consumer groups have a very different role than they do in behavioral health. They actually push payment changes and transparency of data much more than we see in our disease space. I do think that the consumers need to organize in a way separate from providers and other commercial interests and be able to be the ones. My only bumper sticker I've ever put on my car in 55 years is question authority. And I think in this environment, that's actually a great thing to do. And my last slide really is just an outtake. If you haven't read Eric Topol's ebook, The Creative Destruction of Medicine, it's really a great short read. But I just thought I would end with a quote from him. He talks about how the technology, and he calls it the digitization of people, which I know everyone hates the term, but it's really fascinating, is going to cause the positive creative destruction of medicine. But his theory is that if we don't have more active consumer involvement, this will take a much longer time. And he really believes, and I believe him, that most of the guilds, political groups, and others are really not capable of making this change happen, that really the only antidote on the political side is organized consumerism to really democratize medicine. And if you haven't ever seen patient Dave over there, who runs he actually is a recovering cancer patient who survived when he wasn't supposed to and started the whole e-patient movement. But it's really a hoot if you go to his website. He's kind of I would call him the guerrilla cancer patient, and probably not someone you'd want in your office. But he leads an entire initiative called Give Me the Damn Data, which I think was the appropriate way of kind of ending a idea talk on how to get access to new technology. So thank you very much. Yeah.